So is GERD medication causing a B12 deficiency? Do you have acid indigestion and you're taking one of the over-the-counter medications for that? That's going to be our topic of discussion today. I am Dr. Martin Rutherford. I am a certified functional medicine practitioner. I'm also a chiropractor.
Dr. Randall Gates, board certified chiropractic neurologist, as well as being a chiropractor.
So this is a real common topic that comes up in our office. We rarely have people who come here specifically for GERD itself, gastroenterological reflux disease, esophageal reflux disease. And, but yet a substantial portion of our patients come in and have gastroesophageal reflux disease.
Right.
So we're pretty familiar with this, kind of like people come in with fibromyalgia and they all have hypothyroidism, which actually ends up being Hashimoto's. And we've had the opportunity to see how this has an effect on general physiology, because it seems like the physiology that occurs at GERD kind of affects the digestive tract and other physiology all the way down. I kind of throw this in the category of the evolving category of people starting to understand that taking certain medications just for standard procedures are probably not good. I kind of throw it in the category of statin drugs, which people are starting to understand maybe aren't good, with the exception of certain circumstances. I kind of throw it in the category of certain blood pressure medications where we're getting, I think, over medicated. Not to say that nobody ever needs a statin or a blood pressure, but these GERD medications are kind of, in our observations, they're a lot. They're being used a lot. So, and the reason is because the question that is being asked by Dr. Gates in our little outline here is GERD common? And the answer is, it's real common. I mean, it's like super common. Even before I got into functional medicine and I was doing strictly musculoskeletal work, we had a lot of people who were coming in here with acid indigestion, and a lot of them felt they had hiatal hernias and things of that nature. It seemed like half of my patient population was asking me to work on them to see if we can relieve something in their thoracic area so that they could ultimately reduce this acid indigestion. And we were able to do so, but for the most part, it was very temporary because we weren't really addressing the cause of the problem. So let's talk about GERD. Let's talk about how common it is, and let's go from there.
Yeah, GERD is incredibly common, so prevalent in our society. The statistics are just staggering. We have, as Dr. Rutherford mentioned, 173 million over-the-counter packs of GERD medications were sold in 2009. Nexium is the fourth most commonly prescribed medication in our society, with over about 15 million prescriptions written per year. That's just for one drug within the class of gastroesophageal reflux disease. And there are about 7 million diagnoses of this every year. So it's a very pervasive problem in our society. And it was interesting in going through the literature, there's almost little to no discussion as to why it is so prevalent. Everybody will talk about, well, the sphincter where the esophagus meets the stomach, it tends to be too loose and tends to be open for too long in patients who have GERD. But there is really little other discussion as to why this phenomena is occurring at the rate that it is. And we're going to try and go into that today, so you have some more clarity as to why you are kind of relegated to taking a GERD medication. And we'll also talk about, is there efficacy for GERD medications? Yes, but what can you do naturally, potentially, to work with your doctor and not having to be on these for the rest of your lives?
Yeah, normally when a patient comes in here, and for those of you who may not have seen us before, we work as a team. I do the intakes. I'll do the consults. A lot of people come here from far away. We have a lady here right now from the North Pole. Yesterday she came. And on phone, we'll try to do consults to make sure that if somebody's going to be coming here from a long way away, that we can help them. And so frequently those consults can be pretty intense. People are They're looking for answers. And I'm looking to make sure that this person's not going to be making a trip that they shouldn't be making. And it's interesting, as serious as those conversations are, when people start talking about GERD to me, relative to what we do, almost, not that I don't take it seriously, I'm like, yeah, this will get better. That, and I go, well, what about my GERD? I go, oh yeah, that'll get better, because it's really part of a bigger picture. It's really part of a much bigger picture in our world, and that much bigger picture is the picture that ultimately is causing that person to have come in here for some sort of a chronic syndrome like fibromyalgia or peripheral neuropathy or dizziness or vertigo. About how could that be possibly related? So it's funny, I'm getting a lot of more feedback these days, people who are starting to look for what we do. Like, you treat the whole person. Like, by the time you come in here, it's almost like, no matter what you have, we're going to treat the whole person. And this GERD is kind of like part of all of that. It's kind of like secondary to so many of the other things that we treat. Stress, would that be part of it? Would stress be part of it? Maybe we could start with that one. Like, why is GERD so common?
Exactly.
Because of stress. Do you know anybody out there that's stressed? Are you stressed? I'm stressed. He stresses me out.
All the time, constantly. Well, with stress, our body goes into this state of fight or flight. We've mentioned this pretty much in every broadcast. When you're in a state of fight or flight, you're going to activate responses that are going to allow you to do exactly that. You want your muscles to contract as hard as they can. You want the little old lady to lift the car off the child, as an example. You want to mobilize sugar from your liver so that you can run as fast as you can for as long as you can. You want to open up your lungs so you get more oxygen to your body. I could go on and on, but I'll stop there. Also, in that sequence of events, when you're under stress, your body goes into a mode of shutting off certain seemingly unnecessary processes at that time, like gastrointestinal function or copulation. Basically, that means reproduction function within the body. So when we shut off digestion, we don't want food to really move through our intestines. We don't want to make digestive juices in our intestines. We don't want to make hydrochloric acid in our stomach to help break down food. And one of the arguments within the alternative community that was really, I saw, really pushed by Dr. Krosden, and it was also pushed by a lot of other functional neurologists at that time, is that when we're in a state of stress and your sphincter is actually below the stomach closed down so food can't move through, and there's not enough hydrochloric acid in the stomach, then the food will putrefy within the gastrointestinal tract. Right. And then your body will start to make too much acid because the food isn't broken down, and then that can kick back up into the esophagus. And there's also some arguments that that sphincter separating the stomach from the esophagus is going to tend to be loose in that sequence of the fight-flight response.
There you go. And just to bring this a little closer to home, Dr. Gates mentioned the fight-flight response. Essentially what he's saying is, when you need to fight, or you need to flee, or you need to prepare for a presentation or a hard time or whatever, you go into a fight-flight mechanism. That's the stress mechanism. And when you're doing those things, frankly, nature knows you don't need to be digesting food. You don't need to be pooping. You don't need to be peeing. You don't need to be copulating. You don't need those functions, and everything is shifted towards making you kind of like super person for a period of time. And so everything is shifted to the function and to the functions that are necessary to make you stronger, faster, quicker, make your senses better. And ultimately, that's what he's referring to when he's saying that stress mechanism. And that's why your esophagus does what it does under those circumstances. Yeah.
And so we've talked about it at length that pretty much our entire population is in the state of stress, as Dr. Rutherford was,
our entire patient population for sure is under
yes. So many people, they don't sleep enough, they don't sleep well, they wake up late, they drink their coffee, they don't eat a good breakfast, they're rushing all day long, they go home, they're stressed out, they're exhausted, they got kids that they need to attend to. And, the cycle just continues on and on and on. And after a while, the human body seems to break down. And that's where we focused in this area of chronic disease, chronic pain, because so many of our patients have these issues where, in essence, they seem to have an underlying cause of stress and the immune system killing the person. So on that note, we can transition into hypothyroidism.
Yeah, and again, and the same thing. We've done a lot of this work utilizing the basic structures that have been put out by our mentors, Dr. Karazian, Dr.
Carrick.
Carrick, who is functional medicine doctor who developed functional medicine. Dr. Krosian, I think, didn't develop functional medicine, or he developed functional neurology.
Dr. Carrick developed functional neurology.
Yeah, Dr. Krosian didn't develop functional medicine, but I kind of feel like he was the springboard. He was just kind of like the guy. But we've taken these and we've had to put it in a certain order, in a specific paradigm and a logarithm to handle chronic pain. And in the same vein as people come in here for chronic conditions and we learn about stress, we've had to learn about stress, and we've had to learn about how the esophagus is related there. We treat a ton of undiagnosed or poorly managed hypothyroidism because it seems to relate to, I won't say everything, but close to everything. And it certainly can relate to GERD.
And the most commonly prescribed medication in our society is actually Synthroid. We used to think it was the third. Now it's the most commonly prescribed medication in society. Yeah. And so that's pretty staggering that we have
thyroid medication, for those of you who may not be aware.
Such a degree of hypothyroidism in our nation. And then there's a whole other slew of patients whose thyroids are not too far gone yet, but their immune system is attacking the thyroid. 1 out of 4 females that also have a thyroid problem where this association with GERD can be present. So when the thyroid slows down or the immune system is attacking the thyroid, then everything in the body has a tendency to slow down. People tend to put on weight, they tend to be depressed, they can lose their hair, they get edema or swelling down in their legs, and you may not make enough hydrochloric acid. There may also be an association with stomach bacteria termed H. pylori, a gut bacteria, and the presence of hypothyroidism with this element of GERD. Now, they've done studies where some GERD patients, they don't have H. pylori. In fact, a large percentage don't, but some do, and that needs to be evaluated as to why you are getting the esophageal reflux disease.
Because if you have a lack of hydrochloric acid, it's not killing the bacteria.
Exactly. H. pylori.
It's not killing a lot of things like parasites, like things that, it's kind of like, they're like the guards, you know, they're like the sentinels at the, you know, at the drawbridge of the castle. They're supposed to keep things out. And so if you have that lack of hydrochloric acid, H. pylori is something you should look for if you have that indigestion. It can go into other things. And the other thing is a lot of people will come in here, you know, you can lose hydrochloric acid as time goes on, because you just, you know, so if somebody comes in here and maybe they're in their 80s, you know, it could be old age. I mean, in this office, old age is generally not an excuse, but that also doesn't mean that that person cannot be helped without taking the over-the-counter GERD or the Nexium or the, what's the other one, the purple pill, Prilosec. It doesn't mean you can't be helped without doing that. If you have these other issues and you calm them down, frequently the patient will improve substantially, or that GERD will resolve. So I think old age is kind of like one, but it's not one we see a lot. I mean, I can't remember the last person that ever came in here with severe GERD. I mean, we've had people come in here with Barrett's esophagitis, there's like severe esophagitis, where the inside of the lining of the gut, right where it's meeting the stomach, is deteriorating, and it can lead to cancer and so on and so on. That gives you acid indigestion. And we've had those clear up.
And that's really the primary reason why GERD medications are pushed, because they say, well, if you have GERD, you have a 10% chance of getting Barrett's. And if you have Barrett's esophagitis, then you have a 10% chance of developing esophageal cancer. So within those statistics becomes this argument for the mass use of gastroesophageal reflux disease medications such as Nexium and these other PPIs that are over the counter, or they're also using these histamine blocking medications that can have a similar effect. And in the research articles that we've cited in today's broadcast, a lot of them talked about how, though those associations exist, doctors have become a little too rampant in their use of prescribing this class of medications and long-term use of them. And when you use them for long-term, or for a long-term, then you can get side effects. One of the main side effects that can be seen are vitamin deficiencies, specifically B12 deficiencies and magnesium deficiencies. Magnesium deficiencies in the elderly can lead to fractures. B12 deficiencies can lead to a host of health problems neurologically. specifically peripheral neuropathy, degeneration of the spinal cord can be associated with types of dementia. Those of you who have fatigue, we did a broadcast on fatigue last week. Though B12 is not the whole piece of the puzzle to chronic fatigue, it can be a slice of the pie for those patients who are fatigued. So yes, this is very, very important.
Yeah, and again, and I don't know if you might have gone through this in the beginning. I was thinking of something else relative to the fact that most people come here and think they have too much hydrochloric acid. Did you go over that already?
We did not go over that.
So I mean, I think,
well, we kind of did.
Okay, and I think this is an important point to kind of tease out and kind of feature, because the vast majority of the patients who come in here, when I tell them they have a lack of hydrochloric acid, are kind of like, no, I have too much acid. It's like killing me. It's making me. It's like, no. You know, most of the people have a lack of hydrochloric acid. I did hear Dr. Gates did refer to the fact that your food will sit there, it'll putrefy. Then as it putrefies, it becomes acidic, but it's putrefying because you don't have enough hydrochloric acid to break it down, mostly proteins, but there are other things. You can't break it down. And then ultimately what happens is you get this thing sitting there putrefying, and then it tries to go into your nice, for all you alkaline folks out there, it goes into your nice tries to go into your nice alkaline intestines, and your intestines is like, get that out of here. This is like not good. And it kind of like boom, and now here you are with the increased acidity coming up from here, which can be that, it could be stomach, you know, it could be a lot of things. But the point being that I think that to emphasize the point that you are taking a medication that is further decreasing your hydrochloric acid production that you already don't have in the first place. And what kind of got me to say that was the comment on the old age. We have, how many people do we have coming in here in their 70s and 80s who are taking these things, who are old,
already don't have enough hydrochloric
and already
acid.
don't have enough hydrochloric acid, on top of the fact that maybe on top of it, they have a thyroid that's not being managed correctly, and maybe they're stressed out of their mind because they're not happy about getting old or whatever. And so now you're just perpetuating this problem by taking these medications. And it's pretty commonly understood. Dr. Gates, attaches a bunch of references to these presentations, but it's a big seller. But it's a big seller, not to get into controversy or anything like that. It just seems to be, it is what it is today. It is a big seller. It's an easy fix. Gosh, we're still conditioned to, I got that symptom and I took this and it made my symptom better. When you have acid indigestion, it is a sign of other things that are serious, that generally need to be fixed so that your GERD goes away and that you have the tools to keep it away. Another thing that a lot of people don't think, well, I just have to keep taking it. As long as I take it, I'm fine. I stop taking it, I'm not fine. Well, that's not fixing the problem. It's not fixing the thyroid or the stress or any of the other stuff that might be affecting this.
Exactly.
Yeah.
And there is some argument that when you take these medications for a long period of time, it can actually upregulate acid producing channels in your stomach so that you will make more acid when you try to go off of the medication. And that can make it kind of a self-defeating phenomena, because then a person tries to go off, they have even more acid reflux, so they feel even more relegated to taking this class of medication. And Dr. Rutherford brought up a great point about how acid is there to kill off bacteria in our stomach. If there's an appropriate acid, then you're not going to kill off bacteria. And they are now showing that when you're taking GERD medications or these acid blocking medications, you can get overgrowth of bacteria in the small intestines. I attached references today talking about how when you're on these acid blocking medications, you're more likely to develop pneumonia, other gastrointestinal infections, even things like C. diff, which is a very severe form of bacterial diarrhea that is hard to get rid of because you're just not killing this guy off, and it can basically overpopulate your colon and lead to you having 10 bowel movements a day that are diarrhea and potentially life-threatening. So it's a big issue, and one of the articles we attached today, and I'm going to read this because this is a direct quote from the Expert Revolutions in Clinical Pharmacotherapy 2013. There's mounting evidence that PPIs, which are proton pump inhibitors, acid blockers, are associated with serious adverse effects. Practitioners should be vigilant and counsel patients accordingly. And another reference we had in there said non-judicious use, failure to review ongoing need of these medications. So it's out there. Doctors should know about it, but not everybody does know about it, because it's almost safer to give you a proton pump inhibitor from a medical legal perspective,
right? I was just going to say
than
sometimes because they
to
don't want
not
to
give you a proton pump inhibitor and you be 1 out of 100 that's going to develop esophageal cancer from it,
right.
and they're going to sue you. They're going to sue the doctor, and the doctor is thinking, well, you know, screw it, I'm going to protect myself before I take that chance.
Yeah,
so that's really the reality of the situation,
yeah,
for those of you out there.
Yeah, and you can't be hard on your doctor because you can't be hard on your doctor because that, as Dr. Gates says, it's just the lay of the land today. I mean, people are afraid of getting sued. Doctors are afraid of getting sued. There's a lot of attorneys out there who like to sue people, and I don't think I'm out of line saying that. I get all the justifications for it and the rationalizations, but the reality is that the unintended consequences of that are massive. This would be one of them. You know, and I mean, the physiology is there. You know, I've been struggling with this lately. We had what apparently was a controversial issue a couple of weeks ago when we talked about what is functional medicine. It's really had me thinking about it a lot, because functional medicine isn't particularly being taught everywhere as what we're talking about. You know, it made me think, are we practicing functional medicine? You know, I think we're practicing it like to the nth degree, but but even if you read, like I was rereading Dr. Krasian's book on the brain the other day, very interesting book. It's a lot of what we do, a lot of the basics of what we do. And even in there, he says, you know, these are complex issues that come into our offices, the fibromyalgia, these types of things. And it's even stumping the functional medicine community now, because when you go to these courses, who will be talking about functional medicine for diabetes, or who will be talking about functional medicine for the gallbladder or high blood pressure or something like that. But when you're talking about chronic pain, you have to look at all of this stuff. And the relationship to this GERD is, and what's become obvious to me, when somebody comes in here and they have GERD, it's always secondary to some other serious things that are going on. Thyroid, brain is stress. Stress is brain, overfiring sympathetic nervous system. You have an entire digestive tract that may be down the line, maybe causing things that are causing the backup, you know, going up into here, causing you to have acid. And we still have this model of, I'm going to take a pill for it, I'm going to take a herb for it. And I'm not saying pills or herbs don't have a position in getting the person well, but the thing is to get that organ system functioning well again. I mean, really what I've been thinking about is we're working with organ system. We're working with systems. Mostly, we work with the brain and the nervous system, the immune system, and the digestive bowel system. That's what we work with mostly. We work with all systems that are involved, but it tends to, like, if you get those three going, a lot of other things, like maybe most everything, tends to like go away. And so it's a whole different concept, more of a Chinese medicine concept, classic Chinese medicine. Classic Chinese acupuncture is not classic Chinese medicine. I'm like totally all over it. Okay, acupuncture is great, but it's one of an 8-pronged approach that is Chinese medicine. Ayurvedic medicine is not taking the pulse, and I love Ayurvedic medicine, the Indian medicine. It's not just taking the pulse and saying, you got acid indigestion, take my supplement, take my herbal thing that's going to get rid of that. It will get rid of that, but that's not Ayurvedic medicine. Ayurvedic medicine is about calming your brain down. It's about doing meditation. It's about getting your whole system in balance. It's about eating the right foods at the right times, at the right time. I mean, it's very comprehensive. But then these disciplines come here, and it's about, okay, I'm talking to you out there because this is what I get. Well, you know, I don't really need to deal with the GERD because I took this Ayurvedic supplement or whatever you want to call it, potion, and my GERD's under control. Well, your GERD's under control, but you shouldn't have to keep taking this thing for the rest of your life. If your system is functioning normally, unless you've had it for so long that you have damaged your esophagus beyond repair, which we so far haven't seen. I know that probably happens, you know, at some point in time. You should be able to this is the one thing you should be able to get rid of and like keep it under control. Wouldn't you say?
I agree.
Yeah. So anyway, that's just my little editorial there, trying to draw things in the picture and trying to draw things into kind of like I'm trying to figure out what we do here, because I think we do functional medicine. We've put two disciplines together, functional neurology and functional medicine. But I think when you start getting into the complexities of chronic pain and chronic disease, you're doing that, but you have to do it in a very comprehensive fashion. You can't take GERD out of the picture and say, I got acid indigestion. What am I going to do for a doc? Okay, here's your diet. Here's your herb. Do that for the rest of your life. You can do that, but the damage keeps going on. the damage keeps going on. So most people who want a long-term response need a little bit more comprehensive view of that. So that when the person comes in our office, if somebody actually came in here and said, I have acid indigestion, I can't get rid of it, I tried everything, we'd be doing a full neurological exam on them. They'd fill out our 17-page history. We would be looking at all their organ systems, and we would go, this, and this are all the things that are causing your GERD. Candida is another one of those. Everybody comes in here with Candida. It's like, no, it's the Candida. As long as I don't eat sugar, it's that. No, if you have Candida, confirmed, you have other fish to fry way up the line, because Candida is like at the end. GERD is exactly like that. So
yeah, one little isolated example, SIBO, small intestinal bacterial overgrowth. We kind of talked about how when you're on these acid blockers, you can get too many bacteria in the intestines. Now they're talking about this newly acknowledged diagnosis in gastroenterology. I mean, it's not that new, but still some gastroenterologists aren't even aware of it. And it's called SIBO. I don't mean that in a negative fashion. Okay, we're not denigrating at all. Mass respect for the doctors of all
except
disciplines.
the ones who aren't aware of it.
No, but we've had patients where they
Right.
they literally were not that aware of it. And so it's because it's relatively new, and they're now saying that this overgrowth of bacteria in the small intestine can basically produce a lot of gas that won't allow food from the stomach to distill down in the intestines. It creates gas backup, and that can create GERD too. So as Dr. Rutherford was saying, all those variables have to be assessed. We're just touching on a few of them today.
Yeah.
And
but I think it's important that they understand that full picture.
yeah,
I really
agree.
think it's part of what people are looking into to understand, and I think that's really maybe the most important point. It's not an isolated part. There is no isolated parts of your body for the record. Okay. Oh, I had my gallbladder out. I had a cutest girl in here today. Oh, she's the gal from the North Pole. When I was doing her interview, she took her gallbladder and she started having all these other symptoms. I said, well, that's because of this, and then she goes, I knew it. I knew I should get my gall. It's like we take gallbladders out like it doesn't matter. It matters, it's like it matters. It's like it matters. If you have chronic acid ingestion here, it matters. It's not just a matter of dousing the fire. It's a matter of finding out why it's there. So it's part of a bigger picture, and I think that really is an important point to drive home. So that cover it?
That covers it.
Cover it? I think that covers it. So, any questions? We can't answer your questions. We've said that. We love answering questions. It's our life is to try to educate people. That's why we do this. We've been asked to do this, and we've been told we should do this, and we should charge for it, and we should have this, and we should do that. This is too important. There's 120 million chronic pain patients running around out there. The data just isn't getting out there. There's a lot of different theories running around. All I can tell you is we think we know what we're doing about what we do. We know what we don't know. We do a lot of research. He does all the research. I do all the talking to people, and we're just sharing with you what we know and what we use to help to get people well. And so we talk with you for that. Having said that, we can't answer 3 or 4 hours worth of questions anymore. It's just, we just can't do it. We apologize for that. But we do consults, like for the lady that I just talked about from the North Pole, and people from other countries and stuff like that, or people from around the country. We do that. You can look on our website if you want to do a consult. The rules of the game are on there, but unfortunately, we've had to kind of pare that down. And our website is powerhealthtalk.com. Anything else you want to know about any of the things we've talked about, the thyroid, if you want to know about H. pylori, if you want to know about stress, we have hours on there. We're just chatting just like this about what we know. And feel free to access that. And what else? Is that it?
I think that pretty well touches on all of it. Yeah.
Okay, so we'll see you next week. If you do have any interesting topics or topics that are of interest to you that we have not covered, we're open to it. If we can talk about it, we will. If we can't, we'll let you know.
Yeah.
Okay.
All right. Thanks for watching.
See you next week.